Good morning, everybody. Thank you very much for the opportunity to speak today. This is a topic that's very dear to me. I practice CF care, and I'm very passionate about it. I have no conflicts of interest. So my objectives today are to talk about some of the current and emerging therapies in cystic fibrosis, and also to talk about newborn screen and what the implications of that are. So some important things that have happened in the history of CF. It was first described in 1938 by Dr. Anderson. She was a pathologist at Columbia. And after she saw several families with this, they worked out that, in fact, this was an autosomal recessive disorder. Several years later, they had a heat wave in New York and admitted many children who were dehydrated and had salt loss. And so a different group figured out that these kids lose salt, and that actually led to the development of the sweat test in 1953. And it's the test that we still use today to make the diagnosis. Children weren't living very long at that time, and so a group of parents got together and formed the Cystic Fibrosis Foundation. And the CF Foundation has supported a lot of the research in CF. So more than 3 decades later, the gene was finally discovered by Dr. Francis Collins and Lapchi Choi, and it was mapped to chromosome 7. Well, several years later, things were still moving very slowly. The gene was discovered, but there was no gene therapy. And so again, the foundation established this therapeutics development program to accelerate new drugs. And initially, it started out with about 11 centers, and today there are more than 80 centers that participate in this. The other major advance was the advent of newborn screening that started in the early 2000s, and in 2009, this became mandatory in all states. So what does the abnormal gene do? Basically, because of the abnormal gene, you're going to get an abnormal protein, which Dr. Collins and Lapchi Choi called CFTR, which stands for Cystic Fibrosis Transmembrane Regulator. So you either have no protein or you have an abnormal protein. And so you have abnormal ion transport. What this does is it results in abnormal mucus that's very viscous and dehydrated. And so you're going to get this cycle of inflammation and infection and eventually destruction of the epithelium. So until recently, most of our therapies really have targeted the symptoms of CF, So a child has an infection or is dehydrated, we give them fluids, we give them antibiotics, we have enzymes, we have good nutrition. And don't get me wrong, these are very important, and these have been the cornerstone of the treatments. However, what the shift now is to see whether we can target some of the pathophysiology at a more basic level. So this slide is from the CF Foundation's website, and it shows you the drugs that are either currently available or that are in development, and I'm going to be talking about some of these. So let's look at inflammation. So what you can see here is these are 2B bronchoalveolar lavage specimens. And what we've come to realize is that inflammation is a very central component of cystic fibrosis, and it's primarily due to neutrophils, and it's present from very, very early on, even in the absence of infection. So this sample is from a normal infant, and you can see that there are just a few macrophages. This sample is from an infant who has cystic fibrosis, and what you can appreciate is that there are a lot of neutrophils. This is a healthy infant. This baby does not have an infection. So there have been a number of inflammatory agents that have been tried over time. In the mid-90s, we had ibuprofen. A number of studies were done, and it seemed to work, especially in the younger age group. However, as time has progressed, we're now seeing some of the side effects of chronic ibuprofen therapy, like GI bleeds, kidney problems. So it's not really very popular. In the 80s, steroids were tried. And yes, they're wonderful anti-inflammatories, but again, the effect on growth, cataract formation prohibited their use. So now what's being looked at is new strategies to see whether we can target inflammation before it occurs. And that could be by decreasing gene transcription, or inactivating the proteins and products of inflammation rather than waiting and then trying to treat it once it's already happened. And so this is again from the CF pipeline. These are some of the anti-inflammatory drugs that are being looked at. And there's this concept that they call low-hanging fruit. And what's meant by that is that these are already available for other conditions, and so what's being tried is to see will they work in CF. And so they're looking at things like N-acetylcysteine, inhaled glutathione, sildenafil, which is approved for pulmonary hypertension. So all of these are currently in trials, but they're fairly early on. Now, an interesting one is azithromycin. So it's an antibiotic, but it has no anti-pseudomonal activity. However, what we found is that it works as an anti-inflammatory. We don't know the exact mechanism. It may work on the host cells, or it may somehow modify the virulence of the bacteria. What has been seen is that in a dish, if you grow Pseudomonas and then you add azithromycin, you will inhibit biofilm formation. So currently it is used for patients who are colonized with Pseudomonas, but interestingly enough, it also works as an anti-inflammatory in those who are not. So what about infection? So the commonest organism that we have to deal with is Pseudomonas aeruginosa. And what we see is that in infancy or early childhood, there's this period of time where you have no organisms detected, and then you have your first and then your second positive cultures. You may only get intermittent colonization at this point. If that is left untreated, these cultures become persistently positive, and then you enter into chronic colonization. And then eventually the organism changes from a free-swimming form, the planktonic form, to attaching, to forming colonies, and then creating this biofilm that shields the organism from the effect of antibiotics. So the thinking many years ago was that if you got Pseudomonas, you're going to keep the Pseudomonas, we're never going to eradicate it. That has changed tremendously. And what we now know is that during this phase, there is a window of opportunity where we can, in fact, eradicate the Pseudomonas, sometimes for several years. But the point I want to emphasize is that many times these children are not clinically sick. And that's why I tell the parents, it's important for you to be seen, not just when your child is sick, but even more importantly, when your child is well. So here's when we can eradicate it. So some of the medicines, you're probably very familiar with Toby or Tobramycin solution for inhalation. This was licensed in the late 90s. And what you can see here is that the patients who received the Toby, even when they were off drug and they cycled it on and off, they still maintained that positive benefit and the improvement in their FEV1 compared with the placebo. Now, the new kid on the block is inhaled aztreonam, also known as Cayston. And so this now gives us a second antibiotic that we can use against Pseudomonas. So there are very few entirely new classes of antibiotics that are being developed, but what we see here is that they are taking existing antibiotics that may be used orally or IV and then adapting them for use by inhalation. So hopefully Toby is soon going to be available as a powder. That'll speed up the time that it takes. MP376 is actually levofloxacin, which is also being looked at for inhalation. So the big question is, do these strategies work? And again, I hope that what you appreciate from this is that we have had this major shift. The red line here is the Pseudomonas aeruginosa. So previously, what you would see is that by early childhood, most of the kids were colonized. Now we're seeing this delay, and our children are getting colonized maybe in their adolescent years or in adulthood. However, this comes at a price, and the price is that now we're seeing other organisms take the place of Pseudomonas. We're seeing more staph. We're seeing some resistant strains like Stenotrophomonas multifilia. We're seeing a little bit of MRSA too, and that's actually a source of major concern. So the other area that's being targeted is the airway surface liquid. So if you recall, I told you a little bit about what the abnormal or absent CFTR does. So this is a normal cell, and what you see is there is normal transport of sodium and chloride into the lumen from the cell, and so the water is going to follow that, and your airway surface liquid is going to be normally hydrated, and your cilia will function and clear mucus. In the CF cell, what you see here is that there is a defect in this, so the sodium and the chloride essentially are trapped inside the cell, and the airway surface liquid is dehydrated. So you get a secondary ciliary dysfunction, and you don't clear secretions. So there are some drugs that are targeting this. Currently, in phase 3 here is an interesting medication called Bronchitol, and it's actually inhaled mannitol. And how it works is just by being hyperosmolar, it's going to draw fluid into the airway. It has just been licensed in Australia, so it's expected that there's going to be an application here to the FDA. Hypertonic Saline is another very interesting one. And again, what it does is it restores this depleted volume of liquid on the airway surface and helps to restore ciliary function and rehydrate the secretions. How this drug was developed was because kids who surfed, again in Australia, noticed that they felt a lot better during the surfing season. And so really what they were doing was they were inhaling all this salty air. So what about the basic defect? So I'm going to tell you a little bit about the mutation so you can follow me. So this is a normal cell where you have normal CFTR at the surface. There are different kinds of defects. Class 1 is when you have absolutely no synthesis of CFTR. Class 2 is when you make CFTR, but it doesn't get to the surface. So this is what's called a trafficking defect. And this is actually the most common mutation, the delta F508. In 3, it gets to the surface, but it doesn't work. There's a gating problem. And then there are milder mutations, such as 4 and 5, where the conductance may be a little bit altered or the synthesis is a little bit decreased. So again, here are some of the drugs in development, and I'll share a little bit more about these with you, because this is really a very exciting area. So I'm going to say a few words about Ataluren, and I miss some of what Dr. Evans said in the last talk, but I believe that this is also being looked at for Duchenne's. And so how this works is that in the top panel you have a normal cell, a normal RNA and ribosome, whereas in the CF cell you have a premature stop signal, and so you don't get formation of the protein. So how Ataluren is going to work is that it's going to help skip that premature stop signal and enable the formation of a fully functioning protein. However, the more exciting drug, because this is actually hopefully going to be coming within the next couple of years, there are two medications. One is a potentiator. So 4% of patients have this class 3 mutation. The one I told you was a gating problem. So the CFTR makes its way to the surface, but the gates don't open. So what the potentiator does is it helps to open the gate and enables it to function. So you can see on the left side, when they gave patients the VX-770, you actually had a drop in their level of sweat, sodium, and chloride. And this is the first time that a medication has done this. So this is really very exciting. In a dish, when you took CF cells, this is untreated, this is wild type or normal, and then you add the VX-770 to the cells, what you can see is that you are restoring more than 40% of the CFTR function. So what about the other medication, the corrector? So remember, in the 508 defect, the CFTR can't make it to the surface of the cell. So what the corrector does is it picks it up and takes it to the surface, and it increases the density of the 508 at the surface. Again, when this was given to patients, what we see is that there is a decrease in the sweat chloride levels, and it is dose dependent. Not as much as we saw with the other one. Now, the interesting thing was they said, okay, how about adding the two together? And so what you see here is that when you put both the corrector and the potentiator, there is a synergistic effect. And again, you see here, when you look at the CFTR function, this is untreated. This is when you only have the corrector, and this is when you have both the corrector and the potentiator, you're getting more than 30% function. So although these target the basic defect, you need to remember they don't cure the disease. But we think that if you get as little as 25% function, in fact, that would be compatible with symptoms being at a very tolerable level, and this is going to lead to an increased life expectancy and a much better quality of life. So let me move at the end to the diagnosis of CF. And so what we have seen is that there's a much greater risk of complications if we're going to wait to diagnose CF by symptoms versus newborn screen. And today, more and more diagnoses are being made by newborn screen. If you wait for symptoms, it's more than a year of age, whereas by screen, it's a couple of weeks. This means that the patients are going to get referred earlier. We hopefully will get a head start on their nutrition, their growth, have fewer complications, better cognitive function, and pulmonary outcomes. Now, the newborn screen is what I call a two-tiered process. So there's two tests done, and it's based on the IRT. So infants with CF, if you recall, have blockage of the pancreatic duct, and so the trypsin is going to leak into the circulation, and this is what is picked up on the test. The problem is that every state does its own thing, and so there are different cutoff values. Some states will have 2 IRTs, some states will have an IRT plus a modified mutation panel. I think the important thing for the pediatrician to remember is that less than 10% of positive screens actually turn out to be CF. By the same token, a negative screen doesn't mean that you don't have CF, because we are going to miss children who are pancreatic sufficient. There are some challenges, how to get in touch with the family, identifying the PCP, insurance issues, patients who cross state lines, and so forth. At our center, we have to deal with a very large number of referrals for positive IRTs, but we're very happy to do that and help steer them to the lab for a sweat test, which is a more definitive test. So the big question is this worth it? Our patients sometimes complain. They tell us, you are piling one treatment after the other on me. And so I think the answer to that is a yes. This is the median age of survival. And what you will appreciate is the slope of this curve. This is starting in the late 80s. This is the 90s. By the year 2000s, our patients were living a little bit over 30 years. Now, the median age of survival is more than 38 years. That's still very young. Now, are these patients surviving and in good health? Yes, absolutely. What this shows you is their FEV1 for children between the age of 13 to 17. So the green line is the national average. The blue line is the 10 best centers. The red line is us at CNMC. So really, when we hand these patients over to the adult team, they have normal or near normal FEV1, and that's really exciting. The other thing that you can see from here is the yellow line is your pediatric population, the green line is your adult population, and you see what's happening. These two lines are going to converge very soon, and soon actually we're going to have more adults than we have pediatrics with cystic fibrosis. What do these adults do? They are very productive members of our society. They go to school, they go to college, they join the workforce, they get married, they have families. They're very functional individuals. So what I want to stress here is that these advances are very exciting. I think we're on the verge of some very novel treatments that are going to come about in the next, hopefully, few years. But the core of this that has kept our patients going until this time has been the day in, day out care that has been given to these patients by you, the pediatricians, by us at the care centers. So you can see that in 1960, the median survival was only 5 years. By 1980, this had more than tripled. So Beth Harkness is our CF coordinator at Children's. This is her phone number. She's more than happy to help answer any questions. She gets a lot of emails, a lot of phone calls, both from primary care physicians as well as patients. I would like to thank Dr. Komborlis, my chief. He has loaned me some very nice slides, especially the ones on therapeutics. I also would like to thank our patients and their families. I have learned a lot through caring for them. They're really a very unique population.